All right, so I'm going to get started so that we have plenty of time to get a little bit of hands-on ultrasound experience and to make sure that we can get everybody through all of our cases. My name is Youyou Duanmu. I'm one of the assistant professors at Stanford and co-director of the Ultrasound Fellowship. And I have my wonderful co-presenters up here with me, Andrew Pellet, Mike Jones, Mora, and Gabe Gomez. And then two other presenters back there with the ultrasound machines, Pat Lanter and Ashley Hall, who are setting up. So today we're going to be talking about vital valvular views. We're going to be reviewing some high-risk cardiac valve emergencies and give you some tips on how to point-of-care ultrasound diagnose this problem. So we have no disclosures. As emergency physicians, we have a lot of tools in our toolbox to work up cardiovascular emergencies and patients in cardiogenic shock. But one area that's always seemed like a little bit of a black box or hard to approach has been valvular emergencies. Often people come in with undifferentiated shortness of breath, chest pain, hypotension, and valves are on the differential, but we sometimes feel limited in our ability to pick up on this problem. JAMA Cardiology found that 8.4% of cardiac ICU admissions are due to valve emergencies. And so we wanted to give you guys a couple of simple tips to be able to potentially pick this up earlier by using your point-of-care ultrasound. We're not trying to replace TTE with Doppler, but with some of these tricks to be able to detect problems with the mitral valve and the aortic valve, we're going to be able to get you a little bit closer to getting your patient on the right track. So in the beginning, I'm just going to be giving about a 10-minute intro to three of the main types of cardiac emergencies that we see related to valves. And then we're going to break out into 5 different sessions and talk about some of these same concepts in the form of cases. And then we're going to come back and do a little bit of a wrap-up and give you some more resources on how you can read more on this topic. So the main things we're going to review today are going to be how to acquire the standard ultrasound views to be able to look for valvular pathology, how you're going to be able to quantify some of these valvular problems by using color Doppler, as well as a little bit of fancier continuous wave Doppler, but we're going to keep it very, very simple. So the first type of valvular pathology we're going to be talking about is mitral regurgitation. This comes in a couple different forms. Primary mitral regurg is often due to a problem with the mitral valve itself, and it can be from rheumatic disease, endocarditis. And then secondary mitral regurg is often a problem with the LA or the LV becoming too dilated, and the mitral valve cusps have problems closing. And both of these can be related to papillary muscle disease as well. So with mitral regurg, if you have primary mitral regurg, you're often going to see an eccentric jet where you have this reflux of blood from the LV into the LA. And then with secondary mitral regurg, you're often going to see more of a central jet where you're going to have a more linear type of regurgitant jet going back into the left atrium. Grading mitral regurg is probably one of the easiest valvular assessments to do. So this is a good starter valve if you want to get familiar with this type of assessment. You need to obtain an apical 4-chamber view or a parasternal long-axis view, and then you just put your colored Doppler window over the mitral valve and include the entire left atrium, and then you just subjectively quantify left atrial filling. So I feel like POCUS, we love subjectively quantifying things, and this is going to be a rough outline of how you can do it. So mild mitral regurg, you often have a smaller jet, and you really only have less than 20% of left atrium being filled with a regurgitant jet. Moderate is when you have 20 to 40%, and then severe is either over 40 or 60% of the left atrium is filled with a regurgitant jet. A couple of quick examples on what this looks like. So you see that they've gotten that apical 4-chamber view with the color Doppler, and this is a small jet that's filling about 20% of the left atrium, and this is an example of mild mitral regurgitation. Getting a little bit more severe, this is probably filling about 50% of the left atrium. This is moderate to severe. And then here you can see that that jet fills almost the entire left atrium, is kind of swirling around. This is an example of severe mitral regurgitation with an eccentric looking jet. And in a similar fashion, you can do the same type of assessment in terms of quantifying that percentage filling of the left atrium in the parasternal long axis view, if that's easier to get than the apical 4. The second type of valves we're going to talk about is aortic regurgitation. So in a similar way, when the aortic valve leaks, blood regurgitates from the aorta back into the left ventricle, and acute aortic regurgitation can cause acute hemodynamic collapse by overloading of the left ventricle. And the main causes are usually different types of aortic root dilation or endocarditis. So there's a couple of different fancy cutoffs when it comes to aortic regurg, but we're going to focus on the easiest one to perform, which is going to be the vena contracta width. And to perform that, all you need to do is get the peristernal long axis view, zoom in over the aortic valve, put your color Doppler to detect that regurgitant flow, and then you're just going to measure the vena contracta width, which is the narrowest diameter of the regurgitant jet. So in this cartoon, you'll see the vena contracta basically is that narrow part of the jet that is coming out right from the leaflets of the aortic valve. And then in this clip, you'll see when you put color over it, sometimes there'll be some noise, but at some points you can see a pretty clear jet. So you want to freeze where you see the jet the clearest, and then you're going to find that vena contracta, and you're going to go ahead and measure that width. And severe aortic regurg is a vena contracta of over 0.6 centimeters. And then finally, we're going to talk about aortic stenosis. So this is one that we see all the time in the emergency department. How many old people who syncopized and fell do you put in your obs unit to get an echo and see what happens to them over the next 24 hours? Sometimes if you can get a little bit of early information about whether or not they might have symptomatic aortic stenosis, you can expedite them getting on the track for getting a valve replacement or potentially getting more of a cardiology workup instead of being in limbo. So aortic stenosis is caused by thickening and calcification of the aortic valve, and about 30% of our geriatric patients are going to have at least aortic sclerosis, and it can lead to heart failure, syncope, and even sudden cardiac death. So with aortic stenosis, a lot of us have probably realized that when we're echoing some of our patients and just looking subjectively at their valve, you can tell that it's brighter than it should be, doesn't open as well. You start to see signs that they might have aortic stenosis. And then if you add on some objective measures to that, you're going to be able to get a lot more information about whether this should be concerning to you on your differential. So here's an example of a patient who, in their peristernal long axis view, has a very hyperechoic, thick, and stiff aortic valve. You can also see that they have quite a thick left ventricle, which can be a result of chronic aortic stenosis. Now they've developed LVH as well. So if you see this and you want to get another objective measure, so when you're talking to your cardiologist, you have something else to say, I'm really concerned about this patient, there's a couple of different cutoffs for defining aortic stenosis. The one we're going to focus on is the most important one when it comes to something that really objectively says that this is a concern, and it's also the easiest to perform, which is going to be the peak velocity. So to do this, you get an apical 5-chamber view, you break out your continuous wave Doppler, you put the gate through the aortic valve, and then you get the continuous wave Doppler tracing, and then you go ahead and measure the highest point of the wave. So an apical 5-chamber view, you can see that in this view too, the aortic valve is calcified, it's hyperechoic, and then you go ahead and pick your continuous wave Doppler, and then you get your tracing. And you can see that the flow of the blood out through the aortic valve is in the negative direction because your blood is flowing out from the LV down through the aortic valve. And then you simply measure the highest point that this wave reaches. So in this case, this person had an aortic valve peak velocity of a little over 4 meters per second, which is severe aortic stenosis. So we're going to go ahead and break out into our 5 breakout sessions. It's going to be in the back of the room. There's going to be 4 circles of chairs, and then one of the sessions is going to be the ultrasound machines, where if you want to practice some of this technique, we'll have a couple models there that you can practice your echo views on. All right? So I'm going to go back to this. All right. So we're still good on time?
Yes.
Okay, thank you.
Yeah, we're actually pretty good.
Oh, good. Okay.
Got some good beer. Nice. Yeah, right? Exactly. It's really good to see you. Tell your fellow. So what did they got?
small group. I'm just going to be floating, so
Oh, perfect.
you'll have to you'll see me up here. if you want, we'll do that. It's gonna be a little weird.
Oh yeah. Some RBBs. Whatever you want.
Oh, you're good. All right, guys, we're going to wrap things up now. Hopefully you've had a chance to get your hands on the ultrasound a little bit and figure out how to access your Doppler modalities, learn a little bit about how you can apply this on your day-to-day management of patients in the emergency department. So hopefully the next time you guys have a patient coming in with shortness of breath, chest pain, hypoxia, new murmur, unexplained tachycardia, you're going to think about doing a POCUS exam. And I would strongly encourage you to think about incorporating Doppler into your exam. Truthfully, it takes just a few extra seconds once you get familiar with how to access the functions, and it truly can change management and your diagnosis for the patient. Because you may have a normal 2D echo, normal 2D image on your of your patient's heart, but if you don't throw the color Doppler on, if you don't throw spectral Doppler on, you're going to end up missing a lot, and you'd be surprised at the amount of pathology that you'll end up finding if you start to regularly incorporate this into your workup, into your patient management. As Yo-Yo was saying before, I want to just emphasize that this is not a replacement for your comprehensive exam done by the cardiology department. It is more or less, I think, useful for a screening exam to assess whether or not there's the presence or absence of a valvulopathy. Understand that these are just some of the Doppler modalities that are used in a comprehensive exam, and with that limitation, you're potentially going to not pick up every valvulopathy that your patients may have, or you may underestimate or overestimate the severity of disease. So yeah, just to review, for aortic stenosis, things that should hone you in on that diagnosis if you're seeing a patient that have thickened aortic valve leaflets. The valve leaflets don't look like they're fully opening, so restricted movement. They appear heavily calcified, so hyperechoic. You're possibly seeing some shadowing behind the leaflets. So that's going to tell you that perhaps there is a stenotic lesion present, but it's not going to tell you anything about the severity. And so that's where our Doppler modality comes in. So what you'll want to do is you'll get your apical 5-chamber view. You're going to run your continuous wave Doppler through the aortic valve. You're going to switch over to your spectral display, and then you want to look at again, because flow is moving, being ejected out of across the aortic valve, away from the probe. The waveform is going to appear below the axis, and you want to measure the peak velocity. And so the greater the peak velocity, the greater the severity of stenosis. And this kind of makes sense. I'm sure many of you remember back to your MCAT days, to your college physics, the continuity equation. And so it's saying that in a closed system, your flow has to be the same throughout. So if the flow just in front of a aortic valve is 5 liters per minute, and now all of a sudden you have to go through a very tight orifice, that velocity is going to have to pick up substantially in order to maintain that same flow rate. So the narrower the valve, the higher the velocity, the more stenotic the lesion. So in our cutoffs here, again, 4 meters per second for severe AS, 2.5 to 2.9 for mild aortic stenosis. For aortic regurg, again, we're just going to focus on the vena contracta. So this is just the area where the regurgitant the regurgitant jet is at its most narrow, and we're going to be measuring that with, this is going to be obtained from the apical 5-chamber view, and we're measuring, again, the width. If it's greater than 0.6 centimeters, that would fall in the severe category, 0.3 mild, and anywhere else in between would be your moderate category. One thing else you could do is look at the size of the aortic jet and how much it occupies of the left ventricular outflow tract. Again, you're going to do this in your apical 5-chamber view. And if it's occupying greater than 2/3 of the LVOT, then it's a pretty wide jet that's consistent typically with a severe regurgitant lesion. Less than 25% would fall in the mild category. For mitral regurgitation, a couple things we could do. Again, that vena contracta, if it's if it's greater than 0.7 centimeters, you're in that severe category. Less than 0.3, that mild category. Other things you can look at if the is the amount of area that jet is occupying in the left atrium. If it's 50% or more, depending on which study you're looking at, reference you're looking at, that would be consistent with a severe regurgitant lesion there. If you have an eccentric wall-hugging lesion that wraps around to the back of the atrium and then anteriorly again, also consistent with severe mitral regurgitation. And then lastly, for tricuspid regurgitation, the number that I want you guys to remember here is 3. So if what you're going to end up doing is you're going to get your apical 4-chamber view, you're going to run your continuous wave Doppler through the tricuspid valve. Somewhere around 80% of the population is going to have at least some trivial amount of tricuspid regurgitation. So we can go ahead and measure that by running our continuous wave through the tricuspid valve and measuring what the peak regurgitant flow velocity actually is. And if it's greater than 3 meters per second, that regurgitant flow, the patient likely has pulmonary hypertension. If it's less than that, it makes it much, much less likely. And this can be helpful and useful in your patient's workup for, say, PE, and whether or not this supports the diagnosis of right heart strain. So just a few examples to finish things up here. You have a 68-year-old male. They present with 2 years of progressive shortness of breath. They presented to the ER after having a syncope episode while they were working out. You notice that they have a holosystolic murmur, so you decide to do an echo, and this is what you see. So I'm going to take from the audience here. What do you guys think are you seeing anything abnormal here? And if so, what do you think the diagnosis is? So as you can see, we have we're in our apical 5-chamber view. We have the aortic valve here. It's fairly hyperechoic. You're not really seeing the leaflets move very well. So this should hone you into the possibility this patient has aortic stenosis. So if we go ahead and run our continuous wave Doppler through the aortic valve and then toggle over to our spectral display, we can see that the peak velocity is greater than, it's about 4.1 meters per second. So this would actually fall in the severe category for severe aortic stenosis. Some limitations to keep in mind is that if you have a patient who's got severely reduced ejection fraction, they may not be able to actually generate that level of velocity. And so that would be one of the potential pitfalls in using this method. But in your patient with normal EF or near normal, this can be very, very useful in screening. Okay, so moving on to our next case. So we have a 58-year-old male. They present for their 3rd ER visit in 2 weeks for shortness of breath. Last week they were admitted for an asthma exacerbation. They, on their vital sign assessment, are noted to be hypoxic to 85% on room air, and this is their POCUS exam. What are we seeing? Severe mitral regurg, exactly. So if you look at the jet here, we have our color Doppler. It's centered over the left atrium and the mitral valve. We're seeing that we have an eccentric jet here, and it's actually reaching the back of the left atrium and actually wrapping around and then moving antegrade again. It occupies greater than 50% of the left atrium. And if you were to freeze frame this and measure the width of the vena contracta, it would be almost certainly greater than our cutoff of 0.7 centimeters. Okay. Two more cases here. So you have a 40-year-old female, history of oral contraceptive use. They just flew across the country from New York to Los Angeles, and shortly after getting off the plane, they experienced shortness of breath, pleuritic chest pain, prompting ED visit. So what are we seeing here, guys? So again, we have our apical four-chamber view, right? So this patient has several signs to suggest right heart strain. Their right ventricle is nearing the same size as the left ventricle. If you put the colored Doppler over the tricuspid valve, you're seeing that there's quite a substantial amount of regurgitation. And if we take that a step further, and what you would do is run your continuous wave beam through the center of that jet there, your continuous wave Doppler, you're going to get this spectral display. And if we measure the peak regurgitant velocity, it's about 3.4 meters per second. So again, anything greater than 3 is consistent with pulmonary hypertension. So this patient has acute pulmonary hypertension, presumably from acute pulmonary embolus. Okay. And last case, we have a 57-year-old female presents from their primary care doctor's office for hypoxia. The patient reports that they've been having some slowly progressive dyspnea with exertion, and now it's present at rest. What is the diagnosis on your POCUS? Excellent. So yes, I would say this borders on the moderate to severe category for aortic insufficiency, aortic regurgitation. Again, just to recall, flow towards the probe should appear in red, flow away from the probe is blue. Blood should normally be moving out of the or away from the probe through the LVOT, through the aortic valve, but we're actually seeing blood moving towards the probe, so this represents aortic regurgitation. If we look at the size of the LVOT, it's probably nearing 50% or more, close to maybe 65%, which is our cutoff for severe mitral regurg. If you look at the pressure half-time, which we did not go into in great detail here, and I'm happy to talk about it after if anyone would like to discuss this further. When you combine the two together, this would probably fall in the range of moderate to severe aortic regurgitation. So that is it, and we will, I don't know if we have time for questions, but if we do, I'd be happy to take some questions. Alrighty, thank you guys.